Hi, my name is Kathleen Kobashi, and I am the Department Chair for Urology at Houston Methodist Hospital. As surgeons, we unfortunately deal with unintended and unexpected consequences in the form of complications. Unfortunately, we don't talk about it as much as we should, and we're here today to talk a little bit more about that and how we can help our colleagues through these difficult times. I want to introduce my colleague here.
I'm Dharam Kaushik. I'm a urologic cancer surgeon at Houston Methodist Texas Medical Center. I'm happy to be here to talk to Dr. Kobashi regarding surgical complications and how it impacts surgeons.
So, Dharam, as surgeons, you know that we will occasionally experience unintended or unexpected consequences or complications. How do you deal with that?
Yeah, so I think if we look at the data, the literature on this, there's not much in our literature. And part of the reason is it's considered almost like a taboo that you don't talk about complications. You don't talk to anyone, including your peers, your residents, or fellows. The only time we talk about complications is Morbidity and Mortality Conference,
Yes.
where we list all the things which went wrong, but that leaves the big unaddressed question of what happens to the surgeon who experienced complication.
That's right. That's right. I think, of course, we always think about our patients first, and I think that it's very hard on the patients and the patient families. But I think up until just recently, we never really had a whole lot of dialogue about what happens to the surgeon. It's equally, or it's at least equally difficult for the surgeon to cope with. And to your point, you feel very alone because you're often advised not to talk to people about it or share too much about it. So what do you think we can do to improve upon that?
Yeah, so that's a great point, KK. What I feel is yes, you're right. Patients and their family are the first victim
Yes.
of a complication, but surgeon and her team are second victim. And it's very important to address not only the first victim, but the second victim also.
Yes.
And it starts from culture awareness of, of what happens to a surgeon when she experiences complications. Now, we did a big study, and you were part of that study with the American Urological Association, where we sent out survey to thousands of urologic surgeons, and 90% of them responded and said during their lifetime they had experienced serious complications.
Yes. Yes. And that's very difficult. As we found in that study, Dharam, I'll ask you to share that, review that a little bit, but there are a variety of different sequelae, a variety of different physical and emotional and, obviously psychological aspects of your response, effects on us as
Yeah.
surgeons when that happens.
Yeah.
Maybe we can recount that a little bit as to what we found.
Yeah, absolutely. Yes, you're right. So we did the study in 2023, and it took us almost a year to collect the data and analyze the data. And what we found was more than 90% of surgeons had experienced a serious complications. Now, there were two main things which happened. What happened mentally, emotionally, most of them developed anxiety, depression, loneliness, which lasted more than 6 months, some surgeons up to a year. And the second thing was the physical distress they experienced. Some of them developed chronic insomnia. Some of them developed vague abdominal pain, headaches, and all this points to the fact that they experience tremendous amount of loneliness, not only in their department, in their institution, but at home also, because there is no support structure for these surgeons who experience complications.
Yeah. I mean, it is absolutely critical that we have this dialogue. I'm so glad that it's really come to the surface now because we need to help each other. And we need to do that for our own health and well-being and so that we can continue to help patients. I remember also in that study, and you recall, there were some people, we did some live interviews. You remember that to me
Yes,
was
yes,
incredibly
absolutely.
moving. And I found that very educational to me and very, in a way, very heartwarming that I shouldn't say heartwarming, that's kind of the wrong word, but I mean, comforting that we're now having the dialogue and we're in it together.
Yes,
I remember
absolutely.
some people saying, I changed my career path because of this. Or every time, I think that you might have mentioned, every time I get to a certain point in a case, I feel visceral because, that was a tough point in a case here,
Yes,
So, I mean, it doesn't go away, right? I mean,
it
these are
never goes away.
people that were out 30 years into their practice, almost retiring, and they were still remembering this versus some people who, as a resident, said, I'm not going to do urologic oncology. It's too stressful for me.
Yeah.
I was involved in a case where there was whatever complication, and you carry it forward with you for years.
Yes. So most of the surgeons we interviewed, it was a live Zoom interview. We interviewed around 50 surgeons, and these were we were unknown to them. So we are total strangers. And these surgeons got on the screen. Majority of them, when we asked them how do they feel about complication, most of them cried.
Yes.
And they said, you know what? No one has ever asked me how I felt. And they cried.
Yeah.
And we are total strangers. I remember interviewing a surgeon in New York who said, I wish someone would have asked me this 5 years ago.
Mm-hmm.
So they carry that trauma. They have almost PTSD from thinking about the complications. So we actually reached out to the American Urological Association and we said, we want to develop a peer-to-peer networking where we can have, throughout the country, we can have peer-to-peer coaching where any surgeon who experiences complication can call her peer support, which is not related to the institution or to the department, but she can talk how she's experiencing the complication so that she can have some support.
Yeah, and I think that's so important. And you're exactly right. That was very moving to me when people would really bare their soul, and you realize how raw it still is.
Yeah.
And I think we're told, as you know, oftentimes we're told, don't talk to anyone but your risk management and your attorney if it comes to that, because you don't want to admit guilt or whatever it is, whatever the reason for that is. And so you carry this burden. You don't know, you can't talk to your friends and your peers and your colleagues, and you're supposed to just not talk about it because then they can be part of the case or whatever legal implication there is. But so therefore you really are alone, right? And so I think that somehow we have to
change that.
I mean, obviously this kind of thing can really lead to very dramatic and drastic and tragic outcomes, as you know, and we unfortunately know.
Yes, so I agree with you. I think having a support structure for surgeons who experience complication, it starts with department. The department chair has to be engaged with the faculty, especially we are talking younger faculty who are just starting their practice and they experience a major complication. I think that's where we really need to nurture them as a department lead, as a chair or a division head. They have to nurture that faculty. Other thing is the residents who were involved in the case or fellows who are involved in the case, they need support from the program director.
Yes.
And then at the institutional level, there has to be a mechanism, an infrastructure, or blueprint for surgeons to say, you know what, this surgeon experienced complication, maybe a mortality or a very complex morbidity, and we need to support this surgeon. So at an institutional level, there needs to be some policies in place.
Absolutely. That brings to mind several things in my head. First of all, Houston Methodist thankfully has a support structure, but I don't know that everybody even knows about that. So that's something that we asked people. Remember, we said, who did you turn to? Did you have any institutional support? And a lot of people said no, or they didn't know if they even had that available to them.
Yes, absolutely.
So we have to make that front first and foremost. the AUA has really taken this on. I think, general surgery at Mr. Turner in the UK had published several articles, I think, that really started us off on this, and we have several colleagues that have really started to talk about it. I'm actually involved in a course at which I present your paper, the paper that we worked on together. But we're teaching a course at the AUA. This is the 3rd year that we're teaching it, and the AUA is in a couple of weeks. The first year we opened it up to the floor, and to your point, there were a couple of brave souls, the first one in particular, who we opened the floor up to, share if they had experienced any complications and what their experience was. And slowly somebody got up to the microphone and started speaking and wept, right? I mean, it's just visceral, right? And I think maybe cathartic, because one after another after that started to get up and talk about it. And we're surgeons, we've signed up for something that's a very joyful, wonderful, fulfilling profession, but it's not without risk. I mean, we're operating on our fellow human beings, and so complications, unfortunately, can occur even with the best intentions and the best of skill. So, and yet you carry that with you as if you were not trying hard enough, or not, you know what I mean? It's not that. Sometimes complications occur.
Yes, absolutely. That's part of that comes with the package of surgery. My professor at Mayo Clinic used to say that if you have not seen complication in your practice, you have not done enough cases, because as that 5% number eventually will show up. And I think it's very important for us to realize that just because the complication happened, it's not you are, as a surgeon, not a failure. Just because the surgery failed does not mean that you are a failure. There is a distinction between those two things happening. And I think as you're doing for the AUA leadership course, as with the AUA workshop in next few days, I think there's a tremendous feedback from the urology community on more work which needs to be done in this area.
I think what also comes up in this course, the course director this year is Phil Pirazio, and Aditya Bagrodia, he ran it before. And then we have 2 other faculty, Casey Seidemann and Paulina Rayblatt. So it's all walks of life in different specialties and different places in the career, as far as timeline is concerned. But what also comes up, it's the emotional and physical stuff that we were talking about. But there's also, you carry, what are people thinking about me? Do they think I'm not competent? This sort of self-confidence crisis. And then you have to carry like real world stuff with you. Like, what's the legal implication? What is the, there's so much on your shoulders to carry, with you. And so we have to normalize it to the point where people can talk about it and seek help. Just talking about it, to your point about people sort of breaking down, means that we need that emotional release and support.
Yes, and the more we hear about this from surgeons at conferences, at institutional level, more we talk about it, the more we understand that this is part of the process of being a surgeon. It is part of our journey, and we don't have to be alone in that journey. We really need support from our peers, from department, from institution, and even national level organizations to say, we are doing really tough job here, and we need emotional support in dealing with complications.
So I think going forward, to your point, at the resident level, I think really sitting down and talking, more than M&M. M&M is a very clinical dissection of a case, right? And we do support each other. I mean, I think our M&M is very collegial and collaborative and productive, constructive. I think historically M&M hasn't
very
necessarily,
malignant.
Very malignant, where you get sort of chastised and embarrassed. And so thankfully we've progressed from that era in most places, certainly here, at most places I would say. But I think you're right. We should start certainly with some, just maybe a ground rounds that's dedicated to, this is an expectation of what you've signed up for and what we've signed up for, right?
Yeah.
And how do you deal with it, and what we expect you might go through emotionally and physically. That's normal, but that doesn't mean that you go into a hole. You have to talk about it. I think that's a very good point. Actually, from this discussion, we're going to set that up.
Yeah. So I agree. I think what I've seen is when a resident or a new faculty experiences a major complication and they are traumatized, they get PTSD, and they may change their path. They might, and this showed up in our survey.
Yes.
In the paper we published, 20%, 25% of surgeons said they changed their practice. They stopped doing complex cases because they had PTSD or they were scared and they did not want to experience that trauma alone. They were afraid of loneliness. And I think when we get into that mindset of saying no to complex cases, then we are doing disservice to our patient, to our community.
Yes.
Because most of the cases we do, especially at the Texas Medical Center, are highly complex cases, which are referred to us from other urologists.
Yeah, absolutely. On the flip side, I was actually surprised to learn some people just got right back on the horse and did the next case in the same day. And I don't know if that's like sports psychology, people who can have a crash in the ski race and get back up and go to the next race. I mean, how you set that, is that, I guess, that's strength, or is that, you know what I mean? I don't know. The point is that there's such a variety of reactions.
Yeah.
The other thing that struck me, and I shouldn't have been, we're not surprised by it, but that several of our colleagues, really disclosed or shared that they turned to substance, right? Which is a very slippery slope. And so, we're not immune to that in our profession. I think that that's something that we really need to, pay attention to and be aware of, and really help our brothers and sisters through this, right? Help our colleagues through these kind of situations, because they're going to happen, unfortunately.
Yes, so that's a coping mechanism for loneliness, for anxiety, for sadness. So I think the more we talk, the more our community, our institution is aware, I think the better plan we'll have, better blueprint we have, better infrastructure to deal with these issues.
Yeah. Well, thanks, Dharam. It was really good to talk to you about this. Again, I feel very sort of cathartic, but also very settled to, share that with you and know that we are in this together.
Yeah, no, thank you so much, KK. This was great. And thank you for the workshop you're doing at the American Urologic Association in Washington, D.C.
Thank you very
I appreciate
much.
that very much.
Well, hopefully this was of interest to all of you. I'm sure it's relatable to any surgeons that are out there. We are in this together, and I think we need to really pay attention to having more purposeful and intentional dialogue to help our colleagues continue to take great care of our patients. Thank you very much.